Good morning, everyone. Welcome to the Policy Research at Hong Kong IAPS, Chinese University of Hong Kong webinar series on COVID-19 and novel infectious diseases. The outbreak of COVID-19 is drawing tremendous global and local public attention, not only to medical and epidemiological research, but also to interdisciplinary research in behavioral and social science that can inform policies. Unprecedented city-level and national-level lockdowns have given rise to challenging political, economic, and socio-psychological problems affecting people from all walks of life. Quarantines, wearing masks, and social distancing have almost become common requirements around the world. Yet, adoption, compliance, and effectiveness vary across jurisdictions. The economic downturn and strain on the healthcare system pose dilemmas to policymakers. Misinformation and erosion of public trust threaten good governance. The fallout caused by this pandemic and future novel infectious diseases will bring continuing global challenges. More up-to-date and evidence-based academic research grounded on empirical scientific evidence is badly needed for public policy reference. The CUHK Policy Research at Hong Kong IAPS program was established to promote cross-boundary and interdisciplinary collaboration on policy research. We are pleased to present a series of webinars to share the works of our researchers across different faculties on issues related to the pandemic with implication on policy decisions. Today's webinar is on individual and policy responses to COVID-19, local and global perspectives. The pandemic is a coming shock for public health and the economy. We need to understand individual workers' and consumers' responses to coordinate policies in public health and economics. This webinar will discuss two distinctive types of responses to COVID-19: individual self-protective responses and public policy responses. While individuals seek to stay away from risky occasions, such as traveling and staying at Airbnb, the economy faces unprecedented challenges with financial hardships to many industries. Individual behavior and public policies are interconnected. In the following three presentations, we will first illustrate the factors that affect the sensitivity of Airbnb bookings to COVID-19. In terms of public policy responses, we will identify key epidemiological parameters of COVID-19 in Hong Kong. At the same time, we will also compare measures and their effectiveness in context in various developed countries and regions on aspects of testing, contact tracing, and containment measures. Consideration of a combination of individual and policy responses is needed to help control the pandemic around the world. Our first speaker is Professor Maggie Hu, Assistant Professor of Real Estate and Finance at the CUHK Business School. Her presentation will be on COVID-19 and travel activities, local and global evidence from Airbnb. Professor Hu received her PhD from National University of Singapore. Her primary research interests include real estate economics, P2P lending, and empirical corporate finance. Let us welcome Professor Hu.
Good morning. Thank you for attending today's webinar. Thank the organizer for having me on this program. So the title of my presentation is COVID-19 and Travel Activities, Local and Global Evidence from Airbnb. So without further ado, let's go to the presentation. So let's get started with looking at some pictures. So these two pictures are taken at Hong Kong's Shay Au Beach. We see from these two pictures, a large crowd of people actually having fun at the beach, paying little attention to the social distancing orders put in place by the Hong Kong government. So from this, we can see people actually, some of the people are having a different attitudes towards the disease. So despite this alarming situation, the severity of the COVID-19 situation and the various governments' social distancing and lockdown orders, it is not so obvious how people will adjust their behavior, especially travel behavior, particularly considering the different attitudes towards the disease. So in my study, I look at what are the effects of COVID-19 on travel booking activities around the world based on the data from Airbnb. So we focus on three main effects, three main factors. So the first factor that we look at is from the Wuhan lockdown. So the Wuhan lockdown was on January 23rd, 2020. So the initial Wuhan lockdown actually sent the first message to the world about the severity of the disease. Secondly, we look at local COVID-19 severities, basically looking at the number of newly confirmed cases in the local Airbnb markets. Number three, we look at how governments tackle the problem, government policies on lockdowns and inbound travel bans. So Airbnb is the largest lodging company by rooms in the travel industry. So it's providing 2.3 million rooms, much larger than the rest of the groups. These statistics may need to be, this is the most recent I can find. Maybe this number is still growing. So you can see, compare with other large hotel chains, Airbnb is still surpassing them by a large extent. So based on 98 Airbnb markets across 30 countries, we find significant impact from all three factors mentioned above, with government policies on lockdowns and travel bans being the strongest effect. So we first look at Wuhan lockdown shock. So the shock from Wuhan lockdown results in 8.8% drop in booking globally. So global effect is 8.8%. Okay. We've also do some regional analysis and find that this effect is strongest in the Asia regions. In Asia, this resulted in 51%, almost half drop in bookings. But this effect is weaker elsewhere. Number two, we look at local COVID-19 severity. We find that when the local Airbnb market have more infection cases, the booking drop even more. So there will be 8.3% drop in booking reviews and 26.6% increase in cancellation rates for every doubling from daily newly confirmed cases. For example, the case go from 2 to 4 is considered as one doubling. When that happens, you have 8.3% more drop in bookings and 26.6% more increase in cancellations. Next, we look at the strongest effect, which is due to government policies on lockdowns and travel bans. So this resulted in almost 60%, 57.8% booking drop. And the cancellation also increased by 4.5 times compared with before the outbreak. So this is global evidence. We also zoom in and focus on one Airbnb market in London, UK. So we also find consistent evidence consistent with the global evidence. But with these local markets, we can do more detailed analysis. So we look at weekly trends since the outbreak, and we find that booking drops at increasing rates after the outbreak. So until the third week of the outbreak, review dropped 60% and cancellation increased 13.1% in the third week of the outbreak. So besides the demand side effect, we also look at the supply side effect. So interestingly, the supply is quite stable. There's no significant change in listing volumes. The listing volume on all the Airbnb platform in London has been quite stable. Besides, the host actually tried to adjust the price downward by 6% after the outbreak. We also document interesting room type heterogeneities. We compare private rooms versus entire units that's shared on the platform. So we find that cancellation increased 30% more for private rooms compared with entire units due to COVID-19. Besides that, we also find there is less discount of listing price for private rooms compared with entire units. So just now we said that actually host adjust the price downwards, right, by offering 6% discounts. But this discount is less for private rooms. This is consistent with hosts actually demand a risk compensation for offering private rooms because the risk of infection is greater when you are living together with a guest under one roof. So hosts demand 4% risk compensation for offering private room shared accommodations. So this is consistent with the fear of infection in shared accommodations. Contributions. So our study is one of the first global study on COVID-19's effects on global travel activities. We document regional differences by looking at 5 global regions and also document room type heterogeneities by comparing private rooms with entire units. Overall, our findings shed light on market mechanisms by documenting demand drops substantially while supply is moderately stable. So the key takeaway message is that COVID-19 needs to be managed strategically in order for the effective recovery of the tourism industry. So next, I'll talk about how I conduct my study. So first, talk about the data. The data used in these studies consists of 2 parts. The first part is on Airbnb travel booking activities. So we use script data from Airbnb websites. We do it at monthly snapshots by downloading all the listing characteristics, booking prices, reviews with very detailed date stamps. Looking at 98 markets across 30 countries using the first 3 months of each year. 2019 and 2020 as our sample. We use 2019 as our control sample and 2020 as our treatment sample. So the second part is on COVID-19 related statistics. So COVID-19 local statistics is from the Johns Hopkins COVID Research Center, coronavirus.data.gov.uk for London markets. And also, we also collect lockdown travel ban policies from Auravision, restrictions.info, and verified with manually collected news article data. Here, let me illustrate the Airbnb listings. So this is a pretty standard listing online. I trust that you must be pretty familiar with the web page. So I'm just gonna quickly show it and skip to the next one. So here are the reviews. For example, this one have 15 reviews. Yeah, so we just count the number of reviews per day. Okay, so I'm just gonna quickly move forward. So let's look at the Airbnb reviews and cancellations versus COVID cases over time. We look at from January 1st to March 30, the first 3 months of 2020. We divide the entire sample periods into 3 phases, including incubation, outbreak, and favor. So these periods are adopted from a recent paper by Ramani and Wegler, a review of corporate finance studies 2020. So we can see during the incubation and outbreak, from the top is the review and bottom is cancellation. From the chart on review, we don't see much drop until we go to the favor stage. Until about early to mid-March, we see a substantial drop in reviews while the COVID-19 case is catching up. Similarly, on cancellation, we can also observe a very sharp increase in cancellation rates around early to mid-March. You can see cancellation increase from near 0 to almost increase by about 8 times. So you can see indeed during the favor stage, booking and cancellation actually affected substantially. Let's move on to reviews in major Asian markets. Just now, the review and cancellation was for global markets. So this picture shows you the Asian markets versus the rest of the world. So the gray dashed line is representing the rest of the world average, whereas other lines representing major Asian markets. Here we have Beijing, which is the blue line, Hong Kong, which is the orange line. We have other cities including Singapore, Taipei, and Tokyo. So from this we can see Beijing is actually affected the most by the coronavirus. You can see after Wuhan lockdown, around the Wuhan lockdown, Beijing, the bookings in Beijing dropped substantially, and it keep on dropping until to almost zero, reaching almost zero. Whereas all the other markets, although it's also a downward trend, but it's not as substantial as the Beijing markets. If we look at the rest of the world, it's actually quite stable until early to mid-March. It only starts to drop until early to mid-March. So this is consistent with our earlier evidence that globally, the booking only started to see a downward trend in early to mid-March. So besides review data, we also collect lockdown data, lockdown and outbreak data. So for example, Wuhan lockdown is on January 23rd, 2020. We also collect the outbreak data. For example, Hong Kong's first date, coincidentally, is also January 23rd, 2020. So this is for all the Asian markets, but we also do for the entire global markets. Okay. So next, we conduct our difference in difference test to test the effects of COVID-19 on booking activities. So our sample is from January to March 2019 as the control group, and January to March 2020 is the treatment group. Our dependence variable includes reviews and cancellation percentage. We also create an adjusted version, which is scaled by the average YI prior to January 23rd of the same year for ease of interpretation of the results. We interact treat times post. The coefficient beta 2 measures the Wuhan lockdown effect. We also interact treat times post times the local COVID-19 cases severity. This coefficient beta 3 measures the local COVID-19 cases effect. And our lockdown effect is the last interaction. So let me show you the results. Here, our treat times post has a coefficient of negative 0.088. So this implies that there is a 9% drop in reviews due to Wuhan lockdown shock. So if we put this into perspective of booking volumes, so based on the booking volume, based on the revenue reported on the first quarter of 2019, so if we can do a simple back of the envelope calculation, we calculate the lost bookings is 634 million for the first 3 months after the Wuhan lockdown. And if we do it on a daily basis, it's 9.2 million per day lost bookings. So similarly, we can interpret the other coefficients. So 0.06% on this coefficient means that for every doubling the case in the city, review dropped by 4.16%. Similarly, for the lockdown, we find a booking dropped 57.8% due to government policies. Due to limited timing, I'm gonna just quickly go through the regional analysis. So here we find the Wuhan lockdown effect is the strongest in Asia. The orange is the Asian, okay, 51% for Asian. We're very weak in not so significant in other parts of the world. Local COVID-19 severities were quite stable for the rest of, for all the global markets, quite strong. Lockdown also, we find lockdown has the greatest effect in North America, leading to 71% drop in bookings. Potential channels, we explore the distance to Wuhan, and also we look at the mobility of the markets and the government's policy stringencies. For local evidence, we look at Airbnb, as the Airbnb is the world's we look at Airbnb in London, as London is the world's Airbnb capital, and it has no travel ban during the sample period. The lockdown is pretty late, happens at pretty late the sample, which is March 21st, and we can also collect detailed COVID-19 data at the borough level. So we find consistent evidence as a global one. More interestingly, we find that cancellation rates is higher for private rooms compared with entire rooms, okay? So this is consistent with the fear of the infection in shared accommodations by both the host and the guest. We look at supply as well. We look at number of active listing volumes in the markets, we find the supply does not change due to the COVID-19 outbreak or due to more infected cases. We find no significant effect on supplies. And we also look at listing price adjustment over time. So each line on this chart represents a month. So the most recent month, which is March 2020, you can see the price is the lowest. So this is the y-axis is the median price per light. You can see the median price per light for the same calendar dates of the same room is the lowest in March. Compared with February and January, the price was much higher. So this obviously shows that hosts are actually adjusting the price downwards as time goes by, as the severity increase over time. So also run a deep analysis on that and find consistent evidence. We find the price is adjusted downwards after the initial outbreak and also adjusted downwards even more as the local severity increase at the borough level. We also find that the discounts is less for private rooms. So hosts actually asking for risk compensation for sharing private rooms. And this discount is even more for when the local COVID-19 cases is more severe. Okay, let me quickly conclude here. So we document Airbnb booking activity is sensitive to COVID-19 risk, displaying interesting regional variations. And we also conduct local analysis of COVID-19 risk at the borough level in London. We find supply is stable while demand drops substantially. We show room type heterogeneities. So the overall takeaway message is COVID-19 needs to be managed strategically for the recovery of the tourism industry. Thank you. That's the end of my presentation. Thank you.
Thank you, Maggie. Our next speaker is Professor Kin On Kwok, Assistant Professor at the Jockey Club School of Public Health and Primary Care at CUHK. His topic is on epidemiological characteristics of laboratory-confirmed cases of COVID-19 epidemic in Hong Kong. Professor Kwok received his PhD from the University of Hong Kong. His main publications are on infectious disease epidemiology, infection control, emerging diseases, and dynamics models in infectious disease. He is also academic editor of 2 journals, including PLOS ONE and Theoretical Biology and Medical Modeling. Let us welcome Professor Kwok, please.
Thanks, Professor Fanny Cheung, for your nice introduction. It's my honor as one of the speakers in today's webinar to talk about the characteristics of laboratory-confirmed cases of COVID-19 epidemic in Hong Kong from the perspective of infectious disease epidemiologist. So here is the brief rundown showing the flow of today's talk. So I will go through a couple of epidemiological characteristics of COVID-19, including basic reproductive number, effective reproductive number, containment delay, as well as the serial interval. So when a new emerging infectious disease or an emerging infectious disease appears in the population, epidemiologists usually use transmissibility to define the characteristics of the disease. Quantifying the transmissibility helps us to understand the infectious disease epidemiology and design the policy and help the policymakers to design the evidence-based disease control programs. The basic reproductive number is one of the quantity to measure the transmissibility, which is defined as the average number of secondary cases generated by the presence of an infectious individuals in a completely susceptible, well-mixed population. So if this quantity, R0, is greater than 1, that means the disease will continue to spread in the populations. If the R0 is smaller than 1, that means the epidemic cannot be sustained and will die down very soon. Here is the diagram showing how the disease is spread in different generation. Assuming in generation 0, we have only 1 infectious individuals. If the R0 is 3, that means in the next generation, 3 individuals will be expected to be infected. Subsequently, these 3 infectious individuals will further infect the disease to totally 9 individuals in total in the second generation. So in late 2019, SARS coronavirus appeared in Wuhan, and based on a review paper with 15 studies, it showed that the transmissibility of COVID-19 in Wuhan ranged from 2 to 4. So for Hong Kong situation, in the early phase of epidemic in February, January, February, the estimate of R0 is about 0.3. So looking at the countries outside China, so we can see the estimates of R0 ranges from 2 to 7 in the early phase of epidemic in March. So when the epidemic advances, the government starts to launch a suite of non-pharmaceutical interventions, such as mandate masking in the public, closure of school, bars, and restaurants, bans of gathering, fewer infectious contact could be made through this social distancing measure. In this situation, we expect the population is no longer completely 100% susceptible. So on the left is the diagram I showed you before, is the whole population is not immune to the disease. So when all these non-pharmaceutical control measures are in place, we expect some infectious contact could not be made. You can see some cross here. In this case, in generation 0, we have only 1 infectious individuals because of the control measure. 2 infectious contact could not be made, and only 1 infectious contact could be made finally. In the subsequent generations, we also noticed that a lot of infectious contacts could not be made because of these social distancing measure. So in this case, we use another quantity to a more practical form of the R0. It's called effective reproductive number, to estimate the transmissibility, which is the average number of cases generated by an infectious individuals for an ongoing epidemic, given the non-pharmaceutical intervention are in place. So in the future, we expect there will be vaccination. We expect these crosses will also happen in some, that means some of them having vaccination will be immune to the disease, and the infectious events and the infection events cannot occur. So this is one of the examples showing the effective reproductive number in the UK. So at the very beginning, you can see the red line showing the RT is at the level above, above 1, which is around 2. So you can see the vertical line, blue vertical line, showing the effective date of different control measures, including school closure, social distancing encourage measure, lockdown order. So you see a couple of interventions were in place. So after these control measures were implemented, you see the red line go down from 2 to the level just below 1. So of course, if you read the news, the UK government started to ease the lockdown policy in May. So that's why in May, you can see another line, which is also very important, the social mobility. You see the purple line go up after May. And you see, and also the green line showing the testing capacity also increases after April. So after that, the RT keeps at the level below 1 with multiple measures working together. From the NHS website, in addition to using R, this R will correspond to our RT, they also use another metric to talk about the COVID alert level. It's the number of infection. So imagine if the RT is 1 and the number of infection, for example, number of reported cases today is 1,000. That means in the next generation, there will be another 1,000 infections to be reported. So in this case, imagine this case applies to Hong Kong. I expect our hospital system will be very suffer because the number of infection exceeds our hospital bed capacity. So when you try to look at the COVID, I suggest you not to just look at the effective reproductive number. You should also look at the number of infections. Currently, Hong Kong situation is getting better. We only record single-digit cases per day. And also RT goes down to the level of below 1. So it's a good news because two metrics shows we are at a very good condition. So for other European countries, you can see RT is smaller than 1, but the number of infection is still at a high level. So that means the COVID alert level is still very high in these countries. So this is the situation of Hong Kong. As you can see, after 9 months of epidemic, we have already experiencing two main waves. So a lot of media said we have already facing 3 waves. In this diagram, I only define on the left of the panel is a wave 1, is a main wave 1, and on the right is the main wave 2. You can see in main wave 1, a lot of cases were from imported. While in the second wave, majority of cases were local cases. So you can see the red line showing RT. In general, RT is always below 1, but sometimes it goes up to, in the first wave is a 2.39, in the second wave is about 3.04. That means the transmissibility for wave 2 is much higher than that you observe in wave 1. And also you can see there's some line showing the effective date for the effective date for different interventions. You can see the blue line showing the blue line showing some dine-in intervention, and the green line showing the work from home arrangement effective date, and the red line showing the school closure period. So in this COVID-19 epidemic, majority of cases are symptomatic. That means infected individuals will develop the symptoms. The containment delay is definitely one of the quantity we are interested in looking at, because this containment delay is facilitating the transmission of the disease, and policymakers are very interested in reducing this delay to make better control of the disease. So you can see this symptomatic case at the very beginning, he or she exposed to the virus. After the incubation period, the individual developed the symptoms, and he or she will experience some delay because the nature of the disease is very similar to influenza, and the symptoms are very mild. That's why a lot of people expect they are not infected with COVID-19. And that's why there are some delay, we call containment delay, showing the duration from onset to isolation. And after this delay, this individual will definitely be identified sometimes later. And during their hospital stay, they either die from the disease or discover and discharge from the hospital. So this is the result showing 53 cases. We use 53 laboratory confirmed data to estimate our containment delay. So here is the characteristics profile of these 53 cases. Most of them are male, and the average age of the COVID-19 of these 53 cases are 55.7, and majority of them are local cases, and about 30% of them are imported cases. So as I said before, we use 53 cases in the early phase of epidemic. That's why this is the epidemic curve showing the distribution of cases by date of onset. So we do use different approaches to calculate the containment delay. The mean is about 6 to 7 days. And we also use some decent method. It's called the doubly interval sensor likelihood functions to fit the containment delay data to 3 distributions. And we ultimately, we find the estimate is about 10 days. So this containment delay is quite severe range. Using different approaches, around 6 to 10 days. So we also try to look at the associated factor of this containment delay. We noticed that this containment delay shows a significant time trend. We show that the later part show a longer containment delay, and also imported cases have a shorter containment delay. And also one important finding we have is that we noticed that those with a longer containment delay has higher number of doctor consultations.
Yeah. I'm sorry, you have about 3 minutes left.
Okay, I'll try to finish it in 1-2 minutes. Okay, so these associated factors have a public health implications. We noticed that in the early phase of epidemic, we were at the winter flu season. That's why physicians may not be able to diagnose the case between COVID-19 and influenza. And that's why you can see the number of doctor consultation lengthen the containment delay by 2 days. That means those individuals having more doctor consultation will have a higher chance to have a longer containment delay. So that's why the government suggests to use the advanced laboratory surveillance program to implement the collection of the deep throat saliva samples from the patient for active diagnosis tests in Hong Kong. And we also from the later findings showing that this deep throat saliva specimen can help reduce the containment delay, which is not shown in this study, but this is our latest study finding. So, I think that's the end of my talk today. Thank you for your kind attention.
Okay, thank you, Kee Non. Our last speaker is Professor Michael Sung from the Department of Economics. His topic is on containing COVID-19 by testing and contact tracing, evidence from Asia, Europe, and the US. Professor Song received his PhD from Stockholm University. His research focuses on Chinese economy and macroeconomics. Professor Song is a professor in the Department of Economics and also the co-director of the CUHK Tsinghua Joint Research Center for Chinese Economy. Let us welcome Michael.
So thanks a lot, Fanny, for organizing this event and provide us, the great opportunity to share knowledge on this pandemic. And this is particularly important for me and my courses who are completely new to this field. We didn't know anything about this pandemic before, jumping into this epidemiological study. So this is today's presentation will be primarily based on joint work with two of my courses. One is Ke Rong Zhu. Now he's at Zhejiang University, and the other is Fabrizio Zilbotti at Yale. So here is a quick summary about what we know and what we do not know, or what we are less sure about this pandemic. So first of all, thanks to the fast-growing literature, in particular the great work that has been done by many epidemiologists like King Ong, now we understand pretty well what are the major weapons we can use to fight the battle. If we really want to win the battle, so what is the kind of standard of winning? Using King Ong's language, we just want to push the basic productive number, or the effective productive reproductive number below 1. So that's sort of the goal. That's the standard of winning the battle. And we have, in our pocket, we have 3 major weapons. One is containment measures. They are partly from individual responses, like what Maggie has talked about, using the fantastic Airbnb data. It's also partly from policy responses. And one extreme example is this very draconian lockdown we saw in Wuhan. And we understand if this containment measures can be sustained in a reasonably long period of time, then we can stop the spread of the virus. Of course, we also understand that the huge costs associated with these measures. And the second weapon is intensive testing. So that's, once again, it's partly just government policies, it's partly individual responses. If the government can quickly build up its testing capacity, especially in the early stage of the pandemic, then it will be extremely helpful. And of course, you should also assume kind of a good compliance rate from individuals, so they have incentive to show up to demand a test. If you have a combination of these two things, then it's pretty good to tackle the issues. And the third weapon we have is sophisticated contact tracing. We can learn a lot from successful cases from countries like South Korea. Without locking down the cities or the whole nation, they managed to contain the pandemic just using advanced contact tracing technologies. But the problem is, well, for many countries, we don't really have perfect weapons. None of the weapons is perfect. In particular, we kind of a lack of sufficient supply of ammunition. If you think about the draconian lockdown policies, not all the countries can afford huge economic and social costs. If you think about testing capacity, even for a city-state like Hong Kong, it's pretty difficult for the local government to expand testing capacity in a short period of time. Not to say, many developing countries that do not really have deep fiscal pocket. And contact tracing also requires a lot of resources that not every government can really afford. So the things that we are not so sure about is whether or not we can win the battle if, you know, none of the weapons seems to be perfect. So this project is basically trying to answer this question, and we estimate kind of a generalized model based on a class of models that have been developed by epidemiologists. And we estimate a model using data from 3 European countries, Germany, Italy, Switzerland, 4 US states, Connecticut, Massachusetts, New Jersey, and New York, and the 2 Asian countries, Japan and South Korea. The selection of those states and countries, you know, a big part of reason is coming from scientific considerations, but you know, it's also a bit random selection. I will, if I have time, I can explain to you later, you know, why we came up with this this sample. And what is the takeaway message I want to deliver? So I hope, you know, in the end of the day, I can convince you there is a piece of good news. That is, even if you have limited testing capacity, and, you know, there is also limited resources for contact tracing, but putting these two things together, they can be a pretty effective substitute for draconian lockdown. So that's a kind of a good use for us. If we reopen the economy, we don't really have to worry about devastating consequences as long as we allocate enough resources to testing capacity and contact tracing. So I don't really have time to go through all the details in the model. It's basically, you know, the standard SIR or SEIR model developed by epidemiologists. So in this class of models, we basically group people into 4 states from, let me just bring up a pen. So from this S, this is basically the group of people that are not infected. Some of them, once they contract the virus, they will move into this group called E. So in our context, we call it the group of the asymptomatic. So these are a group of people who have contracted virus but have not yet developed obvious symptoms. This is partly related to the containment delay, you know, King An just talked about. If they're lucky enough, they don't really have to have any symptoms, and they will eventually recover and move to the group of R. There's some people who are not that lucky, so they will develop COVID symptoms, and then they're gonna move to this I, and then, you know, eventually everyone will recover. So we don't have the deceased in this model, but, you know, that doesn't affect any of the results, because the deceased will be, you know, just isomorphic to the recovered, because none of them will be infectious in the model. So that's the standard model. What we are doing is first introduce additional exiting channel for those infected. So previously, the only way for the infected people to become non-infectious is, you know, they just recover. And now we can test some of them. We can test some of them in group E and in group I. We can test those asymptomatic, and we can test some symptomatic. Once we identify these people, we can move them to quarantine state. So the idea is, once they are in the quarantine state, they will not be infectious anymore. Okay, so that's why, you know, once you identify those positive cases and move them into quarantine state, then, you know, this pandemic can be effectively contained. So as long as this outflow channel is strong enough. The problem, of course, is, as I said before, in the real world, the cruel reality is many countries do not really have sufficient testing capacity or contact tracing, sophisticated contact tracing technologies. So in that case, the outflow through this mechanism will be greatly affected. So if a lot of things are kind of constrained by limited resources, then the effectiveness of this mechanism, of course, will be greatly reduced. So once again, the question is, how do we estimate that and have a quantitative assessment of the power of each channel in the real world? So I'm not going to show you once again a model, but I really want to show you one line of equation. That's the only equation in my presentation. It's almost like a accounting identity. So it's just for illustrative purpose. We come up with the demand for testing. So how many people will come up and ask for a testing opportunity? So we have three different sources for this demand. So one is, the symptomatic. So those guys who already developed COVID symptoms like high fever and the dry cough. So some of them will show up in hospital, request a test, or some of them will report to the local health authority. So this lambda X is a parameter capturing individual willingness to report to health authority or hospital and demand a test. So basically, the higher lambda X is more willingness or more incentives that the government is providing to individuals, asking them to come up. And the second one is, King An also briefly mentioned about that. Many people may actually develop COVID-like symptoms without being truly infected by a COVID-19 virus. So for instance, those guys who contracted a flu virus, they may develop similar symptoms like fever and dry cough. So these guys cannot really distinguish themselves from the truly infected, and nor can health authority do this. So both of them will show up, both the truly infected and those uninfected but with COVID-like symptoms, both of them will demand tests. So these are the first two components on the right-hand side of the equation, on the right-hand side of the demand equation. And the last part is about contact tracing. So C is the number of people who have contacted those confirmed cases. And this lambda C is a crucial parameter. That's a policy parameter. It tells us how likely those contacts can be identified by the government. So if lambda C is equal to 0, then contact tracing is basically not there. If lambda C is equal to 1, that's great. That's the fully empowered contact tracing technique. Everyone can be identified. So in the end of the day, we're gonna estimate these parameters that determine the effectiveness of testing and contact tracing. One is the individual response parameter, and the other is a policy parameter for contact tracing. I'm going to skip this figure for saving time. It's really about what would happen if we have unlimited resources for testing and contact tracing. Then things will look great. But the reality is we don't have much of resources. So what will we do? So suppose we have not yet build up sufficient testing capacity. So we just follow what has been done in many countries. So for instance, CDC in the US recommend prioritizing symptomatic and the contacts if testing kits are in the short supply. So you're gonna first allocate testing resources to those symptomatic and the contacts of the suspicious and confirmed cases. So this is exactly what we introduce our constraint in the model. So in the end of the day, we're gonna use the structural approach to back out the key parameters for, the effectiveness of the weapons I just mentioned at the beginning of the presentation. We're going to estimate these parameters. The first is the individual response to test, how likely you're going to show up to demand a test if you have COVID-like symptoms. And the second one is a policy parameter for contact tracing, how sophisticated the technology that the government adopts. And the third one is, a measure about the lockdown or containment policy. If N is high, it means, lockdown measure is less severe. If N is low, it means, it's a really stringent lockdown policy so that you don't see much of human activities. So N is basically measured about human activities. And it's also a key parameter affects transmissibility that King Ong talked about. So all the other parameter values are basically borrowed from the epidemiological studies that have been done by people like King Ong. And why we do that? Because we believe that those parameters are basically medical parameters that cannot be or unlikely be affected by policy and individual responses to the pandemic. So what we did for the estimation is pretty standard in economics and in the epidemiological study. We just use a nonlinear least square to fit daily new cases. It's very important to notice that our study using a structural approach for confirmed cases under limited testing capacity is very helpful in the following sense. A big concern in the literature is how reliable, the number of officially documented cases. So there are a couple of concerns, but the biggest concern is this official number. This confirmed cases could be severely underestimating the true cases. But this is not an issue in our study because, by construction, this number of confirmed cases has to be smaller than, the true cases. And that's why we adopt a structural approach to understand how severe this underestimation could possibly be in this model. So now let me use the last 2 or 3 minutes to show you the results. I think that's the most interesting part of the presentation. So first of all, the results for European countries and US states. The first parameter, lambda x, is like the parameter individual response parameter, how likely the symptomatic will show up, will report to the health authority or hospital to request for a test. The interesting thing is you don't see much difference across countries. So this is exactly what we expected. Individual responses are more or less the same across countries. But you see a huge heterogeneity in terms of the contact tracing technology across countries. Italy and some of the US states didn't really have sophisticated contact tracing, so that lambda C is actually pretty low. For instance, in New Jersey, only 31% of contacts can be identified. On the other hand, Germany has adopted the pretty sophisticated contact tracing technology. About 80% of contacts can be identified in Germany. So that explains why, that's actually the main reason why, different countries actually associated with very different epidemic consequences. Germany actually didn't adopt a stringent lockdown policy, but since they have this high lambda C, so they're able to contain the pandemic pretty well. And in Italy, they didn't have the lambda C is much lower for Italy, but instead they relied heavily on a lockdown. So NL is much lower for Italy. Okay, And what about the Asian countries? We confirm our, observations that South Korea has adopted very advanced contact tracing technology. So the lambda C for South Korea is actually even higher than that for Germany. It's close to 0.9. And that's the main reason in our model why, Korea managed to beat the virus without doing any national level lockdown. And Japan is also pretty good. It's partly because of good testing capacity and a pretty decent contact tracing technology. So a quick summary is, well, you can see the long-term consequences by, this highlighted the red box. That's the long-term population share of the infected. So Asian countries, the reason why the long-term population share is negligible is exactly because of contact tracing testing capacity. And US failed dramatically. It's a reflection of a multidimensional failure. They didn't have sophisticated contact tracing. They failed to build up testing capacity in the early stage of the pandemic, and lockdown measures are not that strict compared to countries like Italy with a comparable level of contact tracing. So I think, my time is up. So I'm gonna stop here. Okay.
Yes, thank you, Michael. All right. If there are no other questions, I'd like to thank our three speakers again, and I'd like to see you next time at the webinar. Thank you.
Thank you, Fanny.
Thank you.
And bye-bye.
Bye-bye.